Okay, so we're going to end the session with this talk on our early experience with Lifitegrast. Now we know that dry eye is a multifactorial disease with basically a loss of homeostasis of the tear film instability, hyperosmolarity, and ocular surface inflammation and damage. We do get these severe dry eye patients with aqueous deficiency, and that's divided into the Sjogren's and non-Sjogren's type. The eventual pathogenesis shows an epitheliopathy, sensory neuron activation, goblet cell density reduces, and there's an immune cell infiltration that happens. What we are doing when we are treating with tear substitutes is we are fixing just the tip of the iceberg, so to speak. The options in our armamentarium so far are ocular surface lubricants, anti-inflammatory drugs, punctal plugs, and topical anti-inflammatory agents. Now, artificial tears don't really address the root cause, and corticosteroids are kind of like dropping an atom bomb on this, where you're pretty much causing a lot of other issues like cataract, increase in eye pressure, etc. So we have come up with various different molecules to help counteract these issues, and we have had things like cyclosporin, tacrolimus available to us, and recently Lifitegrast has been made available to us in India. Now, how does this act? It's an LFA1 antagonist. It acts extracellularly by blocking the binding of the intracellular adhesion molecule to lymphocyte function-associated antigen 1, and that's how it brings about its anti-inflammatory effect. So there's a strong inhibition of this T-cell adhesion to ICAM1 expressing services. It's got a high solubility in aqueous media, so it's formulated as a sodium salt, which allows concentrations of less than 100 milligrams per ml to be isotonic with human tears. It's got a reasonably rapid absorption and a relatively rapid clearance from the systemic circulation with a good safety profile, so it doesn't have much of systemic side effects. So what is the evidence? We've seen these studies, the phase 1, phase 2, phase 3 studies. This was the Lifitegrast ophthalmic solution 5% study for treatment of dry eye disease. They looked at fluorescein and lissamine staining scores, the OSDI index, the 7-item visual analog scale, and the ocular discomfort. Basically, there was an improvement in corneal fluorescein staining. The limitations of this study were relatively short treatment time. They did not allow any concomitant therapy with artificial tears or cyclosporin. There was selection only of aqueous deficient subjects. No significant difference between the groups in the primary endpoints were noted, and no significant change on the visual related scales were seen. So the phase 3, the second study that was done, was placebo for treatment of dry eye disease. In this, in the OPUS phase 2, they started evaluating the efficacy and safety of Lifitegrast compared with placebo for treatment of dry eye. So it used adults aged 18 years with use of artificial tears within 30 days, with inferior corneal staining score of 0.5, Schirmer's tear test without anesthesia between 1 and 10, and an eye dryness score of 40. And what this showed again was that there was a little bit better inferior corneal staining with the Lifitegrast group. The eye dryness score became a little bit better, as did the ocular discomfort. The limitation were the subjects were actively using artificial tears, again limited treatment duration, and they excluded subjects with known active lid margin disease. Now the third arm of this study, the objective of the OPUS 3 study was to evaluate the efficacy and safety of this compared with placebo in participants with moderate to severe symptomatology instead of the milder symptomatology. Again, it had a relatively short treatment time, limited to patients with at least moderate baseline symptomatology, and those wearing contact lenses, which form a large part of dry eye, were excluded. To summarize, basically Lifitegrast blocks the LFA and ICAM1 interaction. It's FDA approved treatment for both signs and symptoms of dry eye disease. It's proven to improve eye discomfort, dryness, and visual function, superior to CMC but similar in efficacy to cyclosporin. And the long-term safety profile is good. The other thing that was seen was also on lipid layer thickness. We did not find any kind of a change in this between the two groups. So could these have synergistic effect where they work together? Well, basically cyclosporin works intracellularly, whereas Lifitegrast works externally. So these could potentially be combined together as treatments for mild and moderate dry eye disease. I'd just like to summarize with our initial few cases. This is what we found when we put these patients on Lifitegrast. They did, of course, have artificial tear substitutes going on as well. In general, we found a slight improvement in the Schirmer's and TBOT scores and the OSDIs as well. However, there were cases where there was a lot of stinging sensation, so we did have to actually withdraw the Lifitegrast as well. There was one case like that. So thank you for patient listening, and thank you for being part of the instruction course. I know we ran a little short of time at the end, but I think overall a good discussion. I'd like to thank all my panelists for being here, all the speakers, and a wonderful audience for attending so early in the morning. Thank you.